Okay, good afternoon. Welcome to Digital Health Weekly, brought to you by Luma Health, where today we are going to have a fireside chat to talk about vaccine distribution, best practices, how to think about implementation, the things to think about not only for today, but as we start to move to phase 2 of readiness. I'm your host, Dave Smith, and in today's episode, we're going to speak with Aditya Bansod about all things COVID vaccine distribution. Aditya is obviously well regarded in the health tech community as being a pioneer of many of the distribution strategies and delivery strategies used by clinics and health systems throughout the US. We are beyond excited to have him join us today. Aditya, if you could take a moment and share with us a little bit about your journey into healthcare. Why did you pick this as your place of passion? A little bit about your background for the audience. We'd appreciate that.
Happy to, Dave. It's a pleasure to be here. And I like to joke that photo of me is definitely the pre-COVID-19 version of me, a little bit cleaner around the chin, a little bit better in the hair, but let's pretend like that's what I actually look like rather than what you're seeing in the live video here. So as Dave mentioned, my name is Aditya. I'm one of the founders and CTO at Luma. And just my background is I'm a technologist. I've been working in technology for the last 15, 20 odd years. And for me, about 10 years ago, I made a couple of conscious choices that I wanted to kind of work in software and technology where what you do in your products and what software and technology you build could kind of help shape the way that humans engage with and help citizens of the United States really engage with how they deal with kind of the big kind of life events that happen in them. So I used to work for, say, Fortune 500s, Fortune 10 companies, and I made a career change to start to work for very, very small startups, including eventually founding my own. And I first kind of made that transition at a company called Remind, which is a K-12 communication company, and really scaled that up to be kind of used within about 1 out of 4 of all K-12 systems. And when we had the opportunity to found Luma, it was the same kind of idea. So I'm not like a healthcare person, like it's not something that I've kind of spent 20 odd years on, but I kind of really am very close to, I have 2 people who want to get very tightly connected with each other and to produce great outcomes. So whether it's teachers, students, and parents, whether it's healthcare providers and clinical staff, patients and their doctors, kind of this core mission in my career has been around like kind of using communication to bridge the gap of access. And that's what really helped kind of inspire a lot of what we're doing here at Luma is putting together the opportunity to have these 2 ends connect. And I think that's been really important as we kind of round the corner on vaccine delivery, getting from now up until phase 2, like 1A, 1B, 1C, but also kind of pushing us forward into phase 2 is really how do you get those people who have this like need, the desire to get access to care, whether it's a vaccine or otherwise, and then go from there into actually being able to get care and be prepared for that opportunity to receive said care. So that's kind of me in a nutshell. I live in San Francisco with my wife, kind of been here in the Bay Area for 15, 16 years. So this is home now, but that's a quick backgrounder on me, Dave.
So thank you for sharing that. While I'm not a Peloton user, I'm sure that at the end of this, if there's anybody that wants to ride with you, you can share your Peloton account and
yes, and you're more than welcome to join me on a ride, or if I got maybe some kettlebells and some medicine balls back there if we want to get down and dirty with some other fun stuff.
Awesome. So for the audience, I just wanted to share a bit of context on what to expect over the time together. So obviously, vaccine readiness, delivery, how we think through that's here and now. We're going to really focus on that. But to do that justice, we will explore a number of topics that are inputs and outputs of that. And we want you to be able to leave this session with 1 or 2 pearls of wisdom, perhaps a new best practice, and if anything, just a break from the flywheel that we all find ourselves in, because everybody on this call is somehow, some way shaping the future for our country, which is an unbelievable place to be. We will monitor the chat, so please do, if you have any questions, please hit the chat. We will also make available after this through our YouTube channel and other sources, the audio. And so certainly knowing that most folks are visual, this is a dialogue. We're going to have a dialogue. We're not going through 45 slides. And so it's intended to be a relaxed setting to get experts on who can really opine and give our audience something of benefit. So that's what we're aiming for today. So with that, obviously, as the stage, Aditya, let's talk a little bit about the current surge happening throughout the US. As a leading health technologist, I would love to hear your thoughts on where you think we are as a society dealing with this pandemic.
Certainly. And, I'm by no means an epidemiologist or a physician. So I'll kind of color my commentary with sort of a technologist's and kind of health IT perspective, if you will. So I think one of the big challenges we're facing through wave 2, coming into potentially wave 3 in the spring here, or whether it was 1.5 from the prior months. I think one of the big challenges we're dealing with is just how do we help scale up testing still? That's still such a big part of the kind of conversation where I think technology and people kind of who occupy the shoes that I also occupy can really fit in and kind of help do two things really. One is help America return to work by providing ease of access to testing and test results, but two, also reduce personal anxiety. Received, and I'm sure many of the folks who are listening received COVID tests in the last couple months. And, there's that kind of moment where you're like, I've got the test. And for you as an individual, what can I do? Am I clear to go see friends? Am I clear to hang out with my family? Am I quarantined? That kind of unknown period. And then on the health system side, they're having to dial, kind of make all those outbound connections, send those emails. The difference between how you message a positive test versus a negative test, it's very different. And the kind of the reaction on the other side is very, very important for just kind of how the patient emotes the moment as it's happening to them. A negative test, great. Do we want to send it as a text message? Easy peasy. But hey, as a positive test, what do I do now? Do I need to kind of monitor that patient, cohort them a specific way, provide them guiding resources, put them in a cadence of communication to help them with that process? So I think one of the things is hey, how do we help streamline those operations by making it easy to schedule? And kind of that's helping kind of America writ large kind of get back to work. And then secondarily, how do we actually get the individual patients who are going through this to reduce the anxiety level so that they're able to, be through that what's going to be a very challenging period. Often you're not getting a COVID test because you want to get, your nose picked. That's not super fun. But you're getting a COVID test because you feel like you need one, which means you're probably worried. And so actually enabling that patient experience that drives that really positive outcome, even if it is a positive test result, I think is one of the things that we have to do as kind of a health system and health society to kind of deliver empathetic care towards patients and meet them where they are along so that they can continue to make informed decisions about how they deal with whatever the test result might be.
Thank you for that. On last week's episode, we spent a good amount of time exploring the impact of mental health. Mm-hmm. And we were fortunate enough to have a point of view from a physician who could share what is like providing that care. But what you just shared, I think what extends the conversation a little bit with mental health, just out of curiosity, what you just described, being able to provide this nurtured journey to a patient. Do you see that, if that becomes the norm and the expectation, do you see that ever going back to patients accepting? I would love to hear your thoughts on that.
I think as health technology, as a whole, if you rewind the tape, let's kind of take a slightly different tack. If you rewind the tape, the experience with the physician was very personal, right? And the physician and the nurse. And so I grew up in both Pennsylvania and Michigan and California. And growing up, you had a very personal connection with the nurses that were there, the physicians that are there. And, you take your kids to the pediatricians and they have that very personal relationship with the children. But as you get older, these sorts of things that you suddenly your expectations have changed, right? And so COVID has kind of caused this, if you're going to kind of very empathetically communicate with patients around this, being able to get back to that personal sense of care that physicians want to be able to deliver by and large, talking to all my physicians who we work with and physician friends, but health systems, as they've kind of become like big conglomerated behemoths, they have to really work to operate at scale. We work with some of the largest health systems in the United States, but we also work with independent physician practices. And the refrain is the same, which is, how do I provide this personalized, empathetic, humanized touch with my patients? But I have to do it, at scale because of COVID and having to provide test results and now vaccinations and all that sort of stuff. And so I think the patient expectations should be high, right? And if they're getting higher because of COVID-related health encounters, that's the right ask from patients, right? It's the right ask that physicians, health systems provide this sort of level of personalization, level of care, if you will. And I think it's incumbent, honestly, on folks who are kind of where I sit in kind of my professional shoes to provide systems that actually make that possible. Because a health system deals with, a medium-sized health system deals with a panel that's between 500 and 1 million patients. How do you do that at scale? Even a single physician may provide like a panel between 5,000 and 20,000 patients. That's still pretty daunting, right? And so I think there's a lot of work that we have to do to kind of get some of that, get healthcare, without a space in it, out of the way of healthcare. And so I think that's a really important thing that I think a lot about around how does like the expectations from COVID really start to drive what patients' expectations are in the future. And the obvious way you can layer in another piece of that is virtual health, right? Telehealth. That is a big part of how those expectations kind of change and move over time.
So let's grab on to your experiences thus far, and your point of view on obviously health systems and clinics are just now getting the vaccine. They're getting their initial doses of supplies. It's going justifiably to to physicians and those that are caring for all of us at large. As the supply becomes more readily available, how should health systems begin to think about the decisions they're making today to prepare for that?
Yeah, the CDC has guidelines that I think form the basis of this dialogue, right? But from what we've seen working with our customer partners in health systems and community health systems as well, what the guidelines are and where the rubber hits the road, I think is where the real the challenge lies. And so, we've seen like CDC recommends group 1B to be 75 and older, but about 27 or 29 states, I forgot the last count, have now redefined it and said, hey, we're actually taking 65s and older into group 1B. And on top of that, I've seen various health systems actually say, hey, even though our state guidelines are 75 and above for 1B, we're going to still take our 65s as seniors and start to vaccinate them. So I think there's like a really interesting overlap between, hey, who am I able to actually get scheduled and get moved through my pipeline to actually, get them the vaccine and then the schedule for dose 2, versus what is the very tight and restricted way that, the guidelines might be applied. So it's one of those things where I think the state of the art and the state of the documentation are this kind of mismatch right now. They're like two waves crashing and they're not really landing at the same time. And it'll take a little while for those two things to land together, because the ability to deliver care deliver the vaccine has so many pieces which are kind of outside the scope of pure health tech, like refrigeration capabilities, injectable supplies, the amount of registered nurses, MDs, NPs, RNs were able to deliver the doses. Different, one of the best things that I, and I'm sure a lot of the folks listening today, but one of the best things I think I've kind of learned over the last couple of weeks is every state has different guidelines on who's allowed to administer a vaccine. So some states, you have to be an MD, an RN, an NP, but some will let farm techs do it, right? So you can do it at your CVS's, your Walgreens, your Rite Aids, your Duane Reads. And so I think kind of like leveling those kind of things out and kind of issuing blanket authorizations to kind of let more folks start to do that kind of the operational pieces outside the health tech piece, I think it's going to be really critical to how you actually define what the guidelines are, so that it doesn't actually artificially constrain that supply and demand piece that, that's all over the news today.
Absolutely. Thank you for that. I mean, it brings up a interesting dialogue around controllable concerns and I'll call them real concerns. Real concerns are, is there enough vaccine?
Yep.
Real concerns are what might be the long-term efficacy? Is it, does it last for life? Does it last for, those are, we'll call them real concerns. And then you have controllable concerns, which are, oh my goodness, we have X supply, but we're trying to manage the distribution and the delivery of scheduling and the logistics around that. Perhaps if you could, for the audience sake, I know that you've been at ground zero of what's the term you used the other day? A day is like a week is like a month, in the life cycle of what we're dealing with. Perhaps for the audience benefit, could you lean in a little bit to what are some of the best practices you're seeing, that you're hearing relative to these controllable concerns?
Yeah, so I mean, I think we are right now still, we're living in dog years when it comes to the vaccine, right? And so every day, health systems, myself, partners that I work with are learning kind of what the best practices are real time. And I'll start, Dave, by kind of talking about some anti-patterns I've seen or anti-best practices, and hopefully we can build up from there and kind of shed some light on what folks can kind of work on as we kind of move forward in this delivery process. So there's certain health systems we've worked with who are like, slam the schedule, get everybody on the schedule. And then a week later, it was so successful. The joke I've kind of thrown out is the vaccine is the hottest ticket since Coachella, right? Like people are jumping at the bit to get it. But a week later, they've had to cancel 400, 500 patients off their schedule because they mismatched the dose availability to what their actual supplies were, because their go-in hypothesis was, just get them all scheduled so I know they're there. The second kind of anti-pattern I've seen is, notification to patients without an actionable intent out of them. And so, I've seen a lot of systems kind of spend time, crafting blast messages, email campaigns, voice calls, whatever those might be, which are like, yes, we've got the vaccine, but you can't get it yet. And it's sort of like, it's a tough pill to swallow for a patient, right? They're like, okay, then what do I do about it? And so I kind of find those two to be a little bit concerning, or like, anti-patterns, if you will. And it's no blame to anyone. We're moving real time, right? Like, we're going to make a lot of mistakes as we go. Our goal is to minimize mistakes over time. What I do see is kind of best practices and pro patterns that have been very successful is, first, is limiting the slots that you're making patients available to schedule with to about 80% of what your vaccine supply is. You will find you want to have last minute fills, on-site schedule changes. You're going to find people are no-showing, although what I've seen kind of in the data is the no-show rates for vaccine appointments are the lowest I've seen for basically any appointments, short of like chemotherapy style appointments. People are showing up like over 90%. But you want to keep only book about 80 to 90% of your available slots. I've seen some health systems book 115, 120%, and it kind of does that anti-pattern that we're talking about. Kind of the second best practice I've kind of seen a lot of is enable a wait list of some sort, like make patients, but only do it if you feel like you can actually take care of the patient and you can action them. But patients want an ability to say, like, I know you, large health systems, small community clinic, whatever, you got me. I'm your patient. I have done the thing, and you are going to reach back out to me when either group 1B, 1C, 2, extra supply end of day, because we're seeing that happen, that we just need to fill. And hey, I'm willing to drive the 25 minutes because you need to consume this dose within the next 2 hours. So we've definitely seen that become a really good practice of having patients kind of queue up. And then when doses become available, you message them out to say, hey, available, first come, first serve. And everyone understands. Like, I don't think anyone's actually saying like, no, shame on you that you ran out of doses. Like, everyone gets it, right? People know everyone's in a tough bind. So I think those have been two really good patterns that we've seen, is kind of restricting the actual available schedulable slots just slightly below what's in your kind of your refrigeration system. And then letting patients join on a wait list so that you know that, hey, this is my pool of interested potential phase 2 patients, my potential 1C patients. Because I think the real smart health systems now they're still struggling to get 1B down the pipes, but the real smart health systems are looking to get ahead to phase 2. Phase 2 is going to happen, and if we're kind of running around chasing our tails in phase 1B, 1C is going to be hard, and 2 is going to be even worse. So I think if you're starting to get ahead of that a little bit, you've got an opportunity to build a pre-built wait list. You've got patients who've identified themselves as, I'm putting my hand up, I'm a phase 2 patient that I want to get access to this this miracle. I think that's a really good practice that we're seeing a lot of clinics start to lean forward with.
So what do you think is, what makes that so hard? Because in the words sound easy, but in practicality for the audience, what makes it hard? What are some of the tips that you might suggest? Because again, you know, I live in Denver, and in my access to care is interesting because you know, I was told to expect an email out of the system that the health system that you know, that my doctor is a part of. And I have this anxiety of, oh my gosh, what if I'm going to miss the email? What if it gets put in junk? Do I have, you know, there's a portal there. And I know it's not their intent to do that, but it is a patient. This is the hottest ticket since Coachella. Okay.
Yeah.
I would argue since we've all been alive. So what makes it hard? What makes it hard?
Yeah, I mean, I think there's so much interest where, you know, we've seen lots of examples, you know, with, you know, I was working with a health system in Arizona, kind of a smaller group, and they basically just have on their website, hey, if you're interested, sign up on like a Survey Monkey, right? And that's, I mean, it's not a wrong approach by any means. It's like totally legit approach. But then the administrative burden after that is like, now I have to match them to patient records I already have. Is the phone number the right person? Is it Dave or David Smith, right? Like, you know, is it this, did they put their name the same way? Just the administrative burden after I've got that wait list is, and I've got that registered interest, instead of even calling it a wait list, calling it registered interest, is so cumbersome, right? It's like, now that I've got 50,000 patients who are registered on this kind of pool, I don't have, you know, 400 people to start making outbound dials and say it's time, right? So there's a lot, the big challenges I think are around patient automation is, you know, whether, I mean, I think the demand for this is so high, it doesn't really matter if you're a 5-provider clinic or you're a 3,000 provider health system. Like, the scale is unbelievable on all these sorts of things. We stood up a wait list at a health system in New York State, and they're registering, you know, I think on the order of almost 2,000 patients a day, right? And so it's just wild. I mean, that's basically a patient every couple minutes is saying like, yep, I want to join. Yep, I want to join. Tell me. And I think that scale that you're moving at, it's like, without some level of automation, it's basically you're reverting back to dialing, and, you know, just no one has the manpower to be able to do that sort of thing. So that's the tough part.
Yeah, and again, to you know, kind of tie for the audience's sake, the dialogue that we had last week. I mean, this physical mental burden on the staff is certainly beyond real. And so leaning on technology, which is a good segue into magic dust. So if you had magic dust and you could pull it out of your pocket and sprinkle it on 1 or 2 business processes or advancements, what would you use it on, and why that?
You know, it's funny, like in my role, kind of oftentimes I think about these questions in terms of technology, like I could magically make that technology problem go away. But I think one of the most important parts here in the COVID vaccine is consent and liability. And it's kind of like a less, you know, sexy part of this. But I think it's so important to be able to really scale up. So if you look at a lot of health systems, you know, one of the big pieces they have to deal with is, how do you get patients to sign an authorization for an EUA? How do you sign an authorization for medical treatment for an EUA drug? How do you also get them to sign any financial consents that they might have to do, even though this is being covered by Medicaid and Medicare? You know, there's all this sort of stuff around just consent, which I look at the entire workflow or the journey a patient has to travel through from like I want to get the vaccine to, I've received dose 1. There's so many places I would want to apply that magic dust into it. But one of the ones I think that is actually very possible, kind of just from an overall legislative purpose or from an executive authorization perspective, is saying, hey, you know what? Like, patients can just authorize themselves, right? By the fact you show up, like, health systems are waived of liability, and patients do not have to go through like 45 pages of patient consent. So, because normally if I'm a new patient, and Dave, like maybe, you know, in Colorado, I can go show up at SSM Health, for example, or University of Colorado. I'm not a patient there. The moment I show up for, let's say I was in town, I want to get a COVID vaccine, as weird as that would be, here's this packet to fill out, right? Like, that's detracts from me being able to get access to the care that's readily available, and also detracts from the health system being able to bring velocity into delivery, because velocity is really where we're trying to get to as a health delivery system. So I think it's like, it's a little bit less sexy, it's a little bit less technology-y, but I think it's such an important part of that entire journey, where like consent, authorizations, patient like liability waivers, all that sort of stuff, being able to like kind of drop some pixie dust on that, to use your expression, and say, hey, you know what, for the COVID vaccine, just show up. We'll give you a sticker like you do when you get voted. Like, I voted, I got the vaccine, and you're on your way, and here's your dose 2 shot. I think real health information management people and kind of the legal folks and the health profession will look at that, and like steam will come out their ears. But I think it's one of the things we got to do just to speed that process up, because me as a patient in San Francisco, as opposed to having my primary care doc or the local health authority, now there's 65 different health systems I could show up at to actually go and actually receive dose 1.
So interesting, right? Interesting choice, because it's a big problem, a problem of scale, and
it's velocity, right? Like,
yeah.
Not only do we have to scale at the top end, but the speed at which the water is going through the pipe, we got to get the velocity on that up too.
So, okay, going back, using your term, rewinding the tape just a little bit, to a few minutes ago, you mentioned experiences dealing with Arizona, which is clearly having a progression in the community, and then I also know that that you have deep experiences with community care in dense urban environments.
Yep.
For those on the audience that have that are part of clinics or systems where they have urban settings, but they also have rural or ambulatory locations, how should we be thinking about the best practices to deploy to those very different geographical footprints?
Yeah, I think it's an astute question, Dave, because there's kind of, we work very closely with, say, a large delivery system in Manhattan, a community delivery system in Manhattan. And also we work with like a large integrated health system in, say, in Arizona. So, Manhattan versus Arizona, like as big as Phoenix and Tucson and Chandler and Gilbert are, they're not Manhattan, right? And so those are very, very different kind of flavors of how you have to deliver healthcare. And so, say for like Banner Health in Arizona, one of the things that they've done, which I think has been incredible, and they were very early in doing this, was actually use the Arizona State Fairgrounds as part of their delivery system, right? And Arizona being kind of COVID on the upswing, a lot of community transmission happening there, being able to let patients stay within their car throughout their entire journey. So show up, scan a QR code, receive injection, move through, glass separation, protects the healthcare staff, protects the patients. Very, very effective use of kind of large public fairgrounds, large public spaces. And now you're seeing this all over it. Like, I think they were an early adopter of this model, but you're seeing it everywhere. Like San Diego, Petco Park is now standing up a vaccination site. Disneyland's being used for healthcare worker vaccinations in Southern California. So you're starting to see a lot more of this sort of stuff kind of roll through. And I think it's exactly the right move. But like in the other case, you have like very dense urban settings and also hospital settings, not just in urban settings, but also hospital settings, where you are scheduling COVID vaccine appointments within the 4 walls of a clinic, right? And so I think there's a lot of consideration that has to be going there, like as you do with any ambulatory visit, even in an urban setting, which is, are you performing a zero contact or low contact scenario check-in process? so that patients are trying to stay away from other people in shared air spaces in an ambulatory waiting room. You have all those kind of considerations to occur. So folks like, Ryan Health and a large community health system in Manhattan, they're spending a lot of time thinking about their different sites between Harlem and the Upper West and Upper East sides. How do they actually make sure they move patients through those injection and vaccination flows while trying to minimize patient-to-patient contact, right? So I think there's a lot to consider there. I think folks are figuring it out. A lot of running these kind of vaccination strategies very similarly they ran COVID testing strategies, and I think there's a lot that we learned over kind of scaling up. I don't think we're totally there yet. The scaling up COVID testing in Q3 and Q4 last year, which are good lessons to actually moving patients through physical locations in both that kind of outdoor focus, state fairgrounds, parking lot strategy, but also like city centers and like city areas. Because I think the other thing we'll get to by the time we're in phase 2 is really having pharmacies lean into delivering vaccines. So whether it's your CVS's, your Duane Reade's, your Rite Aid's, whatever it might be, really having them in kind of non-city America, in kind of more rural or more less urban dense areas in America, parking lots are going to be awesome for this. They're going to be a huge part of how this gets delivered. And you're starting to see this kind of pop up all over the news. Like CVS had this really great, I think there's a vaccination booth they've built in the parking lots where like patient enters one door and they exit the other door. So it's always a clean line with a direction demarked on how they're supposed to flow. And so I think those are really good opportunities they have, like as we kind of start rolling out into kind of the pharmacy world of delivery.
Fascinating. Yeah, so much there in your answer that I think is worthwhile of breaking down and unpacking. One of the interesting conversation points. Obviously, we no politics in these discussions, but we've welcomed a new president, and President Biden has announced 100 million in this first 100 days, which is an audacious and would be welcome if we're
it's a get the man on the moon in 10 years kind of comment, right? It's big,
bingo.
Very audacious goal.
Okay, so I also know that that you commonly are quoted as no patient left behind, and that Luma was created in the shape of being able to deliver healthcare in an equal and fair way. Yep. So putting the last component of this, which is to get to herd immunity, we're going to have vaccine equality across communities to achieve that.
Absolutely.
Would love to hear your thoughts for the audience, and in anything you can weave in that you've seen deployed, because I know that folks are now not just in the design phase, but they're in the, okay, so we need this house, we need 4 walls, we're past that stage. Right. And I know that you've been in the middle of that. And so there's this double benefit, right? Which is, if we're successful in doing this, this truly is a societal thing. Yep. It has the ability to do something that we've never been able to do in mankind. At the same time, the blueprints are there. So for the audience, maybe lean in a little bit to both sides of that question or thought, if you wouldn't mind.
Yeah, I mean, I think there's two, like you said, Dave. There's how do we do, like, let's take that that BHAG, that big, hairy, audacious goal, like 100 million vaccines in 100 days. Great, super pithy, amazing goal. There's so much that has to happen, because we do know, you're exactly right, we do know the walls of the house, but we still don't know where the doors are. We know where the plumbing's coming up, but we don't know if it's a vanity, we don't know if it's a sink, we don't know if it's a tub, right? We have some basics. And I'll throw in another wrinkle here, which is today we've got 2 vaccines authorized with the EUA. It's very possible within the next 90 days we'll have a 3rd vaccine, the AstraZeneca one, also authorized within the United States, and which has a completely different dosing pattern than the first 2 do. And so, we've got all this kind of complexity, which is like, do I want drywall? Am I going to look at, brick? I've got all these questions to how to build this house. So I think there's a couple key nuggets that I've been kind of seeing from working with partners like Montefiore Health in the Bronx, Ryan Health in Manhattan, Banner in Arizona, all sorts of these different customers, Salud in Colorado. Number one is the FQHCs in community health are going to be just an incredibly large part of actually delivering, to use your expression, vaccine equity. Because I think getting access to the vaccine is going to become one of like the defining elements of the next, between here and June, July. But there are populations, especially high risk populations, where the social determinants of health work against them. Just getting access to those patients is hard, right? Like if I'm a large FQ, which has a patient panel of 250,000 patients in, say, like the suburbs of Denver, where Salud, for example, Salud Family Health Clinics or Salud Health System, I forget what it's called, operates. If I wanted to call or text my patients, that phone number that they have registered with me may only last for 6 months. And I haven't seen that patient in 6 months. So how am I going to make sure that they get access to that care? I have the care, I have it available. I have, Pfizer, Moderna, AstraZeneca, I have something available to give them. They want it, but they don't know that it's available today. So I think one of the large challenges we're going to face is kind of just awareness down into, the most underserved and vulnerable populations. And, we have large FQ systems who are really looking to, service, parts of America who their role has been to, service the parts of America that don't have access to like ready healthcare, and to provide that in an equitable fashion. So much like the way that we work with those populations kind of at Luma, but also in general, we have to also consider that the vaccine is something of higher importance with a greater calling to actually get that service in front of them. Because we work very, very hard, and FQs, I love working with FQs in community health, because they really do care about like, how is my diabetic panel doing? How is my, am I getting my annual mammographies done? Am I getting my annual colonoscopies, my foot exams? Am I getting those done? Now, I mean, they service a higher calling about my population and my community. So it's really an interesting opportunity here to use that same kind of opportunity to really get in front of those patients where the SDOHs are really kind of preventing getting those folks to access. And I think that's where we'll have to go, like, and I use this word very liberally, but go find the patients that need access to care. They want to, but they don't necessarily know they need how to get it. So like any kind of big effort, I think it comes from both like the health delivery systems, the FQs, the CHCs, the IDNs, all that sort of stuff. But there's a partnership around like the Ad Council. There's a partnership around, departments of public health. We've, as a community, as a society, we've tamped down on smoking by putting advertising into the airwaves that are, taxpayer paid. And, is that something we're going to have to do to get to that 100 million within 100 days and really start educating, saying like, one of the interesting parts I would love to see here, because a link went viral in my friend group, is, hey, in San Francisco, here's the wait list. I didn't see it on Twitter. I saw no ads for it on the radio. I never saw it on TV, like watching TV with my wife. Like, you didn't find it, just happened to go viral in my kind of like, techie universe. But it's there, the city stood it up. So I think we have all sorts of stuff to do to really just start promoting, awareness in the general population of how to get to these resources. And all that kind of money we've spent on COVID awareness, like wear your mask, keep your social distance, wash your hands, that same budget and mental horsepower that got applied to that, we've got to switch that now into delivery of vaccines and education about where to get access to that sort of stuff. Otherwise, we're going to miss large swaths of the population that need to get access to this medicine.
Thank you for that. I think for the audience's benefit, if you'd be open to not necessarily putting a name, but you are starting to see patterns now to how health systems are thinking about getting the vaccine and getting not just the scheduled event, but seeing that whole life cycle. Yeah, maybe if you could just open up Pandora's box a little bit and share with the audience what you have seen. What are some of the deployed tactics being used? Maybe stitch it together for us.
Yeah. So it's that entire journey. That's that entire vaccine, what we call the vaccine operations, right? There's the science around the vaccine creation, but now we're switching gears into vaccine operations and operationalizing the vaccine. And so kind of I look at a best practice, like what could be the absolute best way we could service patients. It would basically be communicate to the patients at the very beginning, either on your website or directly via email, text, voice calls, automated, saying, "Hey, I've got it, but if you're not eligible, join a wait list." Letting those patients who are eligible schedule, and then if there's no slots available, letting them get notified by text or email that, "Hey, we've opened up slots, please try it." So the kind of qualified populations are getting it right now. Then general population gets put in wait lists so that they can kind of get that. However, they get back on the schedule, and then we've got them. And then we want to do sort of what we call, like, effectively, if you use terms from consumer marketing, a drip campaign, right? Hey, how are you feeling? Are you seeing any adverse reactions? Making sure you engage the patient. Because, we started to hear stories around like both post-dose 1 and post-dose 2 on Moderna specifically around certain reactions that people tend to have. So let's communicate with patients, kind of humanize this kind of momentous thing that's happened in their lives where they're going to be able to hopefully return to normalcy soon. And then, one of the important parts that I've really found, this is a best practice we're telling a lot of our partners about, is that dose 2, you're so excited for dose 1. You're like, I'm going to show up. And the show rates there, the no-show rates are super low, the show rates are super high. Dose 2 is so far away that life gets in the way, right? And so letting the patient be able to reschedule that within the window that they are still, where the vaccine can still be efficacious, is so important, because it helps meet the patient where they are in their own life, kind of gets in the way, and as things happen to them, but also provides them the good medicine that they need. So, if you're able to move the Moderna one, for example, plus minus 2 days, and the Pfizer one plus minus 4 days, give the patient an opportunity 4 days ahead of that, saying, your next dose is, let's say February 26th. If you need to reschedule this, you must get it between February 24th and February 28th. Click here to reschedule, and give them that tight window to actually book in that slot. Because things happen, right? I don't know what I'm going to be doing 28 days from now if I was able to get the dose today. And then following up with them post-vac. Hey, are you feeling okay? Hey, you didn't show up for this vaccine dose 2 appointment. For your health and for herd immunity, for example, it's very important that you receive the second dose. Can I help you schedule that? All in a way that kind of meets them where they are on text and on email and voice. So I think this is kind of the pattern. Get them in, make sure they show up, make sure they're feeling okay, and then humanize to make sure life doesn't get in the way for them receiving the second dose. It's sort of those 4 steps kind of are part of what we're seeing as the best practice for operationalizing it, kind of operationalizing it at scale.
Now, I know that you are working with clinics and health systems that are starting really from step 0, and what you just articulated might feel daunting or impossible because of historical digital transformation that's been hard in this space. So what advice might you share with being able to go from where they might be today to having a more comprehensive operation, using your word? Is it impossible? Is it within arm's reach, within a few weeks? Drop some knowledge on the audience here.
I'm super optimistic. And so I'll start with that, because every system I've spoken to over the last 6 years, thousands of health systems, they all have some concept of wanting to be more digital, right? Everyone's got it in their head. Like, people want that to be true. So someone in the organization has a vision. And I think really the important part is having that person be the champion, and then unblock, stand out of my way, I'm parting the sea. And really let that champion kind of run wild. So we've got great champions at some of the health systems we work with that, I was like mentioning, like Banner or Montefiore or Ryan or Salute, where they have a very clear vision of using what we have in our arsenal. Like my bat belt, I know I can throw this batarang because it'll solve these problems, but I know I need a couple other tools in my tool belt, potentially tools like Luma Health, that if I kind of put them on my bat belt, they quickly integrate with my flow, and that helps me achieve that vision. And I can start throwing those batarangs around, my grappling hook, and kind of getting my hands around the problem. I think really good focused health systems could probably go live with an ops plan, health systems or clinics, either side, in kind of like 3 to 10 days, right? Because what needs to happen, right? You've been like staying up late at night, worrying about it, chewing on your nails about it. What has to happen. So if you have partners, inside the organization or external thought partners who have ops guides, again, Luma, we have these guides that are available for our customers and, for other parties, say like, this is our best practice. This is what we've seen. We've administered 10,000 vaccine, 100,000 vaccine shots. Like, this is what's worked. This is what we've learned. This is the language you want to use. This is the copy you want to use. This is the scheduling you want to flow. This is all this sort of stuff. Deploy, right? And so I think the real big kind of mental model, though, is a champion who the executive team has bought into, having that champion get everyone out of the way so they can execute on that vision, and then kind of assembling a cadre of partners, both clinical and operational, behind them to kind of push and part the seas behind them. So that's kind of what I've found to be the way that I've seen the most successful systems get this kind of ops up in 36 hours, 72 hours, 96 hours. Without that kind of clinical plus ops and that champion, kind of that triangle offense parting the sea, it kind of flounders. And so, but it needs buy-in from like the executive level at a health system or from the owners at a clinic.
Awesome, thank you. That's sage wisdom and incredible advice for everybody on the call. So let's downshift now as we make the turn with the 8 to 9 minutes we have left. So you've spoke quite a bit about this digital transformation. What do you see? Because again, with COVID, there was a clear need of evolution to happen at a pace that needed to happen just because of folks having to be socially distant, still needing to see specialists, still needing to get into a health system. So business, while it certainly was constrained for health systems and clinics, it went on. And over time, we learned because of this transformation. Well, all of us that have been impacted by the pandemic now use DoorDash, we order our groceries, and the famous saying is, once you get convenience, you never go back to, once your definition of convenience gets established, you never want to go back. And I would argue that this transformation, this mobile first, this patient, meet the patient where they're at, what's going to stay? What's going to go back to how do you see the next year, 18 months playing out? Because I've heard folks, experts like yourself, say the next year will accomplish 10 years worth of work.
Yep.
Because consumerization is here. The patient has now been experienced and exposed to this patient first strategy. So it's not going backwards. How do you think about that? And what are some of the advancements that you think that that health systems can be excited about moving forward?
Yeah, I mean, I think the biggest one, let's look at the last year, then play the tape forward, maybe actually 10 years. Because I think like it'll be 10 years happening in a year, and there'll also be 10 years happening in 10 years. And so you kind of have like both, I think, to deal with. And so I think one of the biggest areas we'll see a marked shift in how healthcare engages with patients is telehealth, right? The convenience of that is incredible. It's important for patients to be able to access care without necessarily having to come in for care. And I think a lot about like the service lines that, say, community health plays a part of, where if you're working with a migrant worker or a laborer who might be able to like get only lunch off, but otherwise they have to take the entire day off, that's incredibly powerful, right? That's a whole access to patients, and patients getting access to care that they wouldn't necessarily been able to get access to. And that applies down into like knowledge workers, right? Like taking a day off for a doctor's appointment versus being able to carve an hour out on your calendar to see the doctor. I think there's so much that could be happening. I think we're just at the tip of the spear on this around what the long-term benefits of that will be. Getting access to care, hopefully not in a wasteful way, obviously, but getting access to care in a way that lets you get ahead of like potentially preventative issues. So I think that's super duper interesting. I'm like incredibly fascinated by the evolution of telehealth and how it will happen. And I think if you play the tape forward maybe 10 years, I think the next generation will be a lot of stuff around remote patient monitoring and patient reported outcomes. And that's in the sense where, we have a plethora of devices, I have some friends who work at Abbott who make the continuous glucose monitors, the Libre Views for diabetics. And those are so interesting and so important to basically, manage, chronic conditions, whether it's diabetes or kind of what's coming in the future, where being able to monitor that over time and actually make clinical decisions for a patient without them necessarily having to, come in for lab work every, 6 months or whatever it is, or every year. I think that's so important and so interesting that there's so much health IT that's going to have to meet the moment, because getting 300 blood pressure readings a week is just information overload, right? Like no clinical person, no clinician can make heads or tails of that. And so there has to be kind of like a meet in the middle between all these new devices that are happening and the clinical informatics that have to stand behind them. But I think that's this really nice evolution of let's call it video visits to true telehealth. Like, I think we're going to cross that chasm somewhere in the next 5 to 10 years. But then if you kind of rewind back, like what's going to happen, I think sooner, is to enable that to happen, is I think there's going to be a plethora of new ways for patients to access all the different aspects of their healthcare. So whether it's Apple Health Kit, being able to plug that into all sorts of different health systems. So, whether you can view, like here in the Bay Area, Sutter Health or Dignity Health, like kind of in your just native environment on your phone, your lab result, super, super interesting, better, higher quality conversations. But also, like, how do we deal with the non-platformed patients who don't have apps, patients who don't have Apple Health, Google Health, whatever it might be, with really lightweight text-based identity and text-based like conversations. So like kind of in some ways you can call it like mini portals or portal adjacent. So be able to access all that. So it's kind of a word vomit, a lot of verbal diarrhea here, but there's so many different elements that are going to happen because patients have gotten used to digital, they've gotten used to virtual, they've gotten used to tele, that all these pieces are going to come together where it's going to be, do you want to get an app for your health system? Maybe. Do you want it to live inside your Apple Health Kit? Maybe. Do you not care to install anything? You just want to be able to click a link every once in a while and get access to like whatever you need to get access to? Maybe. Do you need to like, combine all these experiences into a cohesive experience that connects with, when I just go to www.myhealthsystem.org, right? So how do you kind of combine all these pieces together? And I think we've unlocked, due to COVID, very specific workflows, right? That patients have grown accustomed to convenience, whether that's telehealth, online rescheduling, online booking. But I think combining those things into a journey that lands in true telehealth rather just video visits, I think is this journey that we're still going to be on, that I think patients need to keep pushing. And, I'm a patient myself, we're all patients. We need to keep pushing on that factor where health systems are going to have to meet the patient where they are to deliver that kind of consumerized experience. Because I think we're actually, COVID's helped. We sped up kind of this innovation 10-ish years, right? But I think we're still got 20 to 30 years to go to really get to the place where it's truly a consumerized experience in the way that, and I don't mean that in saying, one of the funniest things, I talk to a lot of health systems, they're like, booking an appointment should be as easy as booking like a plane ticket, and you should be as easy as that. I'm like, yeah, but there's also 50,000 healthcare systems in the United States, right? And there's 3 airline carriers. It's just, they're not the same question. And, I'm going to go see this one for my specialist, and I'm going to go see this one for my generalist, and maybe I go to this other place for my imaging because it's cheaper. So putting that whole story together for me, the patient, is a lot more complicated than buying a United ticket that gets me to New York City, right? And so I think that sort of thing, combining those journeys for those patients, is still like, we're still got a lot of work to do to put a patient first approach into it. So, and that's sort of long-winded, but I think there's a lot there where the market as a whole is still trying to react to what the patient wants to do.
Yeah, that's a hell of a vision, and I think for the audience and the audience's benefit as we wrap up, I hope today was useful. I hope you walked away with a best practice. I hope you walked away with some hope, some education. If we can keep this conversation going, we'd be thrilled to carry this forward. I know that those that are here will make available as a resource the podcast, the audio, the video, and as we wrap up, thank you so much. Here's contact information. Next week, we're excited to welcome one of our treasured customers who's going to come on and give perspective and point of view more to the entire dialogue happening. Aditya, thank you so much for making the time, sharing your Peloton with us. And for those that want to ride with Aditya, you have his email, and I'm sure he'll share that with you. But I wish everyone a wonderful afternoon. Thank you again for joining us for this dialogue. It's important, and we're grateful. Thanks, everybody.
It's been my pleasure.